Diana, one of the things is, where does this all come from, right? So we're so data-driven as a group, but yet treat and extend has occupied the majority of our treatment regimens. Where do you think this comes from? Is it a practice flow standpoint? Is it a patient expectation standpoint? What are your thoughts on that?
That's a great question. I think initially it was a practice flow issue because it was burdensome for both the patient and their family and also the physician to monitor someone every 4 weeks. But fortunately in retina, we do have the benefit of having clinical trial evidence. And now we do have level 1 evidence, both for treat and extend through the Lucas study, which showed that it was non-inferior to other modalities of treatment. And then we also, for as-needed treatment, we have the CAT study, which provided long-term data as well on monthly therapy compared to as-needed treatment. Mm-hmm. So now whichever regimen you choose, you can have confidence in the discussion with your patient.
Quan, we've learned a little bit from the initial studies, and we thought there was a lot of either macular atrophy or geographic atrophy, however you want to classify it. What are your thoughts now on some of the studies that are showing about GA or macular atrophy progression? Is it a real thing in anti-VEGF therapy? Is it related to the disease state? What are we seeing here?
So I certainly would start out with indicating that the evidence we find, and first notified by the CAT study that a number of patients you already mentioned who were noted to develop atrophy, I believe that this is certainly very much a disease specific, because clearly we use anti-VEGF therapy in other diseases such as diabetic macular edema or vein occlusion, but we do not see that. So it's most likely related to the aspect of the disease itself. And in my mind, I think having seen a number of literature on this and also research aspect from this, is that probably one of the concerns we worry about is that when we try to eliminate this neovascularization, if we do it too quickly, and then probably maybe, or too chronically, there may be collection of cells and other factors that localize that contribute to the atrophy. So one of the things that we look forward to the future is that not just completely eliminate them, but probably stabilize them. And because perhaps one of the reasons why atrophy developed is because there may be a need for this neovascularization, this new vessel. So rather than just completely eliminate them, if we can stabilize them, that may help to eliminate or decrease the risk for atrophy. But again, as you already alluded to, it's probably a disease-specific, because we know we don't see that in all the disease types.
Mm-hmm. Lloyd, when we have these patients in our practice and we go through year 2, 3, 4 of therapy, do you change anything about how you approach the patient? You mentioned a little bit about the intervals and things like that, but anything different you do? Do you do an angiogram every year to assess their activity? What's your kind of gestalt for that sort of patient?
Yeah, for me, it's primarily clinical exam and OCT. Because I don't think we have a lot of information on what to do with angiograms and ICG late in the course of therapy. I'm not sure what I would do with that information clinically. Mm-hmm. So really, I use OCT as a primary measure of disease activity, and even late in the course of treatment.
Mm-hmm. Diana, how about you? You see this patient year after year. Is there a need to go back and look at the ICG or the angiogram in these patients, or are you using OCTA now as part of that process?
I agree with Lloyd. OCT is definitely the workhorse in a retina practice. And I think the role for fluorescein angiogram is maybe if the patient is not responding in the fashion that you expect them to, so it might be a diagnostic dilemma, it might be a masquerade. Perhaps the patient has polypoidal choroidal vasculopathy, and you might change your treatment by adding photodynamic therapy laser. In regards to OCT angiography, I think that is a new wave that we'll be seeing more and more in clinical practice as we garner more evidence. And the benefit of that is, of course, it's non-invasive, but it will still give you an in-depth view of whether or not there are vessels in areas where there shouldn't be.
Mm-hmm. Those are very fantastic points.